The next stop on our voyage is going to be called Social Data of the Future. Our moderator is Lauren Gerard. Lauren is the VP of Business Line Management for Contexture. Karen Brown is the Director of Strategic Initiatives at A New Leaf. And Elva Hooker is currently the Clinical Administrative Director of the St. Vincent de Paul Virginia G. Piper Medical Clinic in Phoenix. And Amy, I'm gonna butcher that last name if I try it, so bear with me, y'all. Amy is going to be the CEO of the Human Services Campus in downtown Phoenix. Please put your hands together for our next panelists.
Good afternoon. I'm so happy to be here and share more about our Community Cares platform and how we are supporting those closed-loop referrals, the social needs. So part of our Access Whole Person Care initiative, we were charged with bringing together a platform to offer to our participants through that program. And it is enabling our participants to do screenings, through Prepare tools, and then we're also able to do those closed-loop referrals. So really working to build up our system, and we are about 11 months in to a relaunch of our Community Cares platform. So really excited to have the conversation today. So jumping in, Amy, I'm wondering, what does health equity mean to you, and how does it relate to social determinants of health?
Thank you, Lauren. When we think about equity, and I pulled up some information so I could speak more intelligently than just Amy's opinion, equity means fairness and justice, and in the health context, I think it means that we're ensuring that each individual is treated fairly and with more customized services and treatment than a one-size-fits-all approach. So when we think about how do we achieve that, it is about how do we think about making each person as healthy as possible and valuing each person for where they're at, improving social conditions so that it improves people's health. And when we think about the social determinants of health and where people work, live, and play affects their overall health, then we start to think about things like housing in neighborhoods. We start to think about access to nutritious food. And when people are making decisions between how do they pay for each of those things, if they can't pay for all of them, then they're not going to have health equity, and we know that those determinants of health are not equally available to everyone in our community. At the Human Services Campus, for those who don't know, we serve people experiencing homelessness, and we talk about housing as healthcare. And when someone doesn't have a home, they can't address any other area of their life to be healthy.
I would say in addition to that, some of that health equity also means that everyone has access to the highest level of health care, regardless of the factors that affect access to their care, such as the ability to pay or social and environmental or other injustices or obstacles.
And I would just add, just from the experience in working in a free clinic and working with individuals who are considered working poor, they do have housing. Many times it's a partnership between those individuals who are having the health crisis or the health condition and the provider, or even the lay people who are helping the providers during those consultations and those interactions. Really, the provider and those lay people being the first interaction to address those social determinants of health that are really going to make health outcomes more equitable among vulnerable populations. And so one of the biggest things is, who are these individuals? Do they know about social determinants of health and how they are going to, as Amy said, make it fit for that individual versus that, well, we're going to prescribe such and such medications, this is the management plan, but it doesn't take into consideration any of those other social determinants of health that really will impact how that outcome, that health outcome results for that individual, their family, and their communities.
Thank you. What barriers have we faced in addressing social determinants of health in our healthcare system and in our community? How do we overcome those barriers? through tools such as community cares?
I think that has a lot to do with something that Community of Cares is trying to fill a gap in that service for. And really it is that there is a gap in communication among community stakeholders, among patients, that really affects the results of health outcomes for individuals. And that causes a lot of barriers for those individuals and those patients. And then knowing for the individuals, the providers, the lay people, the community stakeholders who really want to impact the community and those individuals who have these health conditions, them being aware of all of the resources that are always changing in the community and knowing where do I refer this patient that doesn't have the same needs as this other patient or this other client that I have. And it's really hard to begin to understand the individual that we're serving, but also really keep up to date with the community service around us. And so what community care does is really create a hub for us to know what is available, what we can refer to, and then also then connect us with what was the status, what was the follow-up of that interaction and that referral, so that we don't feel like, well, it's just an endless pit of like, okay, try this contact number, try this, and it's really not that effective when it comes to helping connect our patients and clients.
I would add that funding is a barrier. It's been for nonprofit organizations are not really funded adequately to provide services that address social determinants of health. And so rate changes and payment models in 2018 created a hardship in Medicaid healthcare, and the pandemic further complicated those challenges. And high rate of burnout among our workers providing these services created additional challenges that organizations are vying for the same grant opportunities. And Community Cares is helping address that by creating opportunities for relationships between community-based organizations and healthcare providers.
Lauren's just making eye contact to get us to talk. Again, at the Human Services Campus, for those who may not be familiar, we have 15 organizations co-located near the state capitol, 12th Avenue in Madison. And you would think that would mean co-location leads to easy collaboration and a coordination of care. And it doesn't. The campus has been open 18 years now. And this kind of conversation, sharing data, how do we best serve the people that show up expecting us to really end their homelessness? Some of us have to use a system called Homeless Management Information System, or HMIS, because we have HUD funding. That's not tied to the state HIE. Many of our organizations are not licensed providers. We don't bill Medicaid. We haven't found that way to bill for the social determinants of health, like Karen mentioned. And so it's not helpful to the people we serve. And we talk a lot about being client-centric. We see 13,000 people a year, and they may be coming in first for a meal. There's a St. Vincent de Paul dining room. They may be coming in first for shelter, and they're not thinking about the next steps related to employment and having a Circle the City medical clinic and a dental clinic, and how can they access all of these services. And so in some ways, you know, we're giving a client a list of resources and a map, and here's how you can find things on this 13-acre campus. And as we got into the community cares conversation, we're not implemented yet. We're beginning our rollout and looking forward to the day that client information becomes real time. HMIS isn't real time. HMIS doesn't connect to community cares yet. I'm going to be optimistic that we as a community will figure out how to make that happen, because a barrier is what will be double data entry, potentially triple data entry, that someone coming to the Human Services Campus could be asked multiple times to complete an intake, an assessment, and a housing plan. And for people living in toxic stress, it's not healthy to keep asking them the same questions over and over again when they're in this space of co-located services. That's why we're really looking forward to implementing community cares, having a way to have real-time data. And when someone said, you know, closed loop referral system, how do we actually close the loop? on all those referrals to resources to know that the person we're serving has everything they need and sets them up for success, which in our case is permanent housing.
I really loved all those points, and I think one thing I would tie into this conversation is with the Community Cares platform, we're actually able to provide back some of that data to help support grants to bring in more of that funding into the organizations who need to support the community. So really excited to see that start to roll out and continue to build how that can overall improve our community in Arizona. So we touched on this a bit, Amy, when you talked about, I don't want to have to do that same screening over and over again. It's hard for our clients that we serve. It's hard for us to have to ask those questions. So one of those things that Community Cares can offer is really implementing that one screening assessment that would be available for everybody using the platform to see those results. But Elva, I am wondering what it would take to ensure that health-related social needs and social risks are universally screened, and how Community Cares, again, can support that.
I think that Community Cares is already starting to resolve some of those issues in the sense that, there's a shared platform where many organizations can come and use and unite in trying to connect individuals to health services or services that address those social determinants of health that really will impact their health outcomes. And that shared platform creates a more continuous continuum of communication between these different organizations, knowing if that loop is actually being closed for individuals. But I also think that it creates some confidence within the organizations, the providers, the individuals that are connecting this vulnerable population to resources by giving them the confidence that they are going to receive some sort of treatment, that they are going to receive some sort of meaningful interaction that will help address, if not alleviate or support, some of the social determinants of health that they're facing. Many times in our medical clinic, one of the biggest things, if we didn't have the next step after a patient was evaluated for an eye screening, well, you have cataracts, but we can't do anything about that, so come back in a year. It would really discourage providers from being a part of something that just had a dead end. And so I think this creates meaningful communication for that and really provides that encouragement to providers, letting them know that we will take care of our clients and our patients by having this system that will allow that seamless communication. Oh, what happened to this client? What happened to this patient? And so I really think that's part of it. I think it also is going to take, champions within organizations to adopt, to utilize efficiently these tools that are available to address these risk factors and these barriers for our clients, because when we're able to do that, really it's gonna, sorry, I lost my train of thought, but really what it's gonna be able to do is allow for that seamless communication. I'm sorry, I just lost my train of thought. So, but all in all is just being able to have confidence within our system for the providers and the patients, but also have that continuous communication and transparency.
I'll add a little bit to the screenings that you mentioned at the beginning. So A New Leaf has a variety of different programs. And we launched Community Cares organizationally wide in January of this year. And we created 2 different organizations. We launched actually 34 programs on Community Cares, and they're part of 7 different pillars of service. And all of those pillars have different assessments that they have to use that are either required by funders or due to the population that they serve. And so we've been looking at using a more standardized tool, which is in community care, is the Prepare assessment. We already use that with our behavioral health services, and we're transitioning to use that more with others. However, we are still required to use a lot of those other assessment tools.
I just wanted to add that in that same context, what I wanted to say earlier was that that leadership is really important in implementing the standardization of those tools. And when there is this top-down dissemination of what should be used, it's a lot easier for providers to use that and take that on than it is when use whatever you like, or rather this is the highly recommended because also the tools are more efficiently available and usable within the system.
So adding on to some of the additional challenges related to collecting data related to social determinants of health, social and behavioral health needs, are there unique challenges particular to specific populations such as the unhoused or Medicaid population, and what can be done to address those challenges? Amy, I'm interested in your perspective for the unhoused.
Thank you, Lauren. If you've seen the news about the zone in downtown Phoenix, that's the neighborhood around the Human Services campus. We don't call it the zone, we call it our neighborhood because people do live and work there, and I think the zone is meant to be derogatory. But if you've seen it on the news, you know where we are, and this morning our outreach team counted 480 plus people who are unsheltered while we're sheltering 900 people in 4 spaces on the campus. So that's, 1,300, 1,400. It's been 2,000 people. There have been as many as 1,000 unsheltered people right outside of our gates because we don't have the space to shelter everyone. And when people ask, why is this person still out here? Or, where are they on the waiting list for housing? There are so many, I think, healthcare-related examples that they're exacerbated the longer that someone is unsheltered and that they're unhoused. Because again, if you don't have a home, you can't possibly be fully healthy. And we come into situations where people don't have medication storage. So if you have insulin, probably not. I'm not a doctor or clinician. Probably not good, though, to have your insulin outside in a tent through this excessive heat summer that we just had in Phoenix. We have many people who are disconnected from their clinic. They've forgotten who their case manager is, or their case manager has turned over. They have old business cards that have phone numbers that don't work or don't go anymore. Clinic names have changed. And they'll tell an outreach worker or a housing navigator a whole bunch of things, and people they've been in this work for a long time may be able to piece things together and go, oh yeah, that clinic used to be named that clinic, and oh, I know for sure this case manager doesn't even work in this field anymore. But those disconnections from care make it extra challenging to reconnect people to care and to find them the best type of supported or resourced housing. And so it's frustrating. It's sad to watch people who are probably unsheltered longer than they need to be. Certainly, I think that any of us would like for them to be. And so how can we map out those connections to systems and the systems of care to really understand, are there policy changes that we could put into effect? Are there rules or criteria that, even if it's a funder-based criteria from Medicaid, is there a way that we could explain these challenges in these situations and the barriers to alleviate? So I haven't verified this yet, but I was told by a housing navigator that a client that we've worked on various housing placements, none of them seem to stick. But the latest thing I heard was that the black and white photocopy of his identification was not being accepted, and we had to wait until he got a replacement identification in full color so that we could provide that for the photocopy. And if that's true, that's, to me, unacceptable that we leave someone outside waiting for a full color copy. So, potential solution, I do have an idea for a solution, Lauren. It's not all whining about all the challenges. we've started working with a program called Keep in the Northeast, which is a digital wallet. And the idea is that any piece of paper, document, so I don't carry them around and drop them, I can scan them in and it goes into an app that's free for nonprofits to use. And so thinking about those ways to not only share data in community cares, to serve all that documentation that's continually required for people to prove who they are and what they have and what they might need next, how can we also digitize that so that, again, we're sharing it with each other, we reduce the length of time that people are waiting for that next connection. That's my soapbox.
Anything you'd add, Elva or Karen?
I think you just hit the nail on the head. Really, it's sort of the same issue when it comes with healthcare management. Our patients are overwhelmed with all the information they get when they are discharged from an emergency room. They have lack of access to transportation. They have economic burdens. They don't know where to get labs, imaging, and all of these different things that they're going to need. On top of that, feed their families. And so it becomes a very overwhelming factor. And they also are, unfortunately, poor historians of what is going on. So being able to have this continuity of information that can be easily accessed between organizations that we're referring patients out to alleviates some of that burden, that confusion, and that duplication or contradiction for their care management in our community. Also, the fact that I could say, oh, Joe got referred to such and such, resource, food bank, and Joe says, no, I never did. I don't know what's going on, what we're talking about. And so being able to have that information clearly stated in one place, we say, hey, don't worry, we have the information that was given to you. We know where you were referred. They know about you. And it really comes back to a better utilization of resources. I would say a better equity for healthcare for our patients, because we are serving them to the best of our ability rather than spending a countless amount of time trying to just piece these things back together and just try to figure out where they have been and where they haven't been.
And Karen, I know you have a unique perspective about how we set up your organization, Community Cares. If you could share more about that.
Yes. I shared earlier that we onboarded 34 programs, and we divided our programs up into 2 different organizations as set up because we wanted to really ensure the security and confidentiality of our clients. We elected to set up a sensitive organization to protect our behavioral health and domestic violence populations. And so with the sensitive organization configuration, it allows us to ensure that referrals sent by our sensitive organization or to our sensitive organizations are only visible to the sending and receiving organizations, and that they're not visible by other network partners. And the protection extends to all information on the referral, including documents and notes.
Thank you. So Karen, coming back to you, how can we measure success in this work? How will we know if our actions within Community Cares are actually making a difference?
Well, I think we can measure success by tracking results. Results such as improved health outcomes, increased housing stability, reduction of 911 calls. And in community care specifically, it's increasing efficiencies, really closing the loop. So getting that confirmation when you're sending a referral has been really important. And then the opportunity to build relationships between healthcare providers and community-based organizations.
And specific, again, from the homeless perspective, those of us working in this intervention space, serving people who have lost their home, we really look at, are we reducing the length of time someone is experiencing homelessness, and are we reducing returns to homelessness? So did we get the housing intervention right? Or do we support someone enough so that the housing we referred to for them sticks and they don't return to homelessness? And so when I thought about this in a larger measure, if we're all working together to increase access to services and reduce the length of time people wait for things, and we're helping more people stay housed, by supporting people who already have a home, if they're low income, how are we supporting them so that they don't fall into homelessness? And so maybe a longer term measure is even, does homelessness go down because we've increased health equity?
And one of the biggest measures in our area, and I speak mainly for our medical clinic at St. Vincent, but is being able to reduce down emergency room readmission. How are we contributing to that? If we are able to connect these patients and get them into established primary care, and then also connect them to some of the other resources that impact their health, like lack of nutritious, healthful food, physical opportunities for physical activity, the economic burdens that really come with taking care of their health are really going to be massive for a patient to really turn around and improve those health outcomes. And so we want to be able to measure all of those, what kind of issues or barriers does the patient come with, and how many of those were resolved through their interaction with our organization.
Thank you. So yesterday I was actually able to sit in a meeting with our Unite Us vendor and have the conversation about how is our platform looking, how is the health of the platform. And I am really proud to report we have over 600 healthcare sites active in the system on Community Cares. We have over 70 community-based organizations, which results in thousands of programs available in that. But we also recognize we're able to take that data, we're able to dig in and see where do we actually have resource gap, acknowledging we need to build out those community-based organizations, those programs that are available for those closed-loop referral. We're also able to now see our off-platform referrals, and so really encouraging that new workflow to then be able to target those organizations, go out and do some outreach where we're seeing those most off-platform referrals. So one of the conversations I wanted to have with all of you was how can healthcare organizations, since we have so many on the platform today, really partner with community-based organizations and other community leaders on interventions to support health equity and encourage them to be a part of the platform.
I could just start with any partnership starts with trying to bring in meaningful relationship that has a win-win for each of the partners. And when each recognizes the expertise and the value that that's being brought in, they're more willing to collaborate and work together. And if an organization can champion, Community of Cares, or can champion what the initiative or the mission that's being done with that partnership, it really becomes a much easier process. I think when partnerships come kind of in a forced manner, there isn't really someone to kind of advocate and lead the way for each of those organizations to really collaborate and make a difference. They fall apart, with funding or no funding, and so I really think that any of these number of organizations can identify a champion that really believes in the cause and also believes in the utility of Community of Cares, and really bring it together and sort of infect everybody else with the value that they find from it.
I'm going to go ahead and state the obvious. We as social workers don't have the skills necessary to address primary care. And the same is true with primary care providers. They do not have the necessary expertise in social care work. Basically, I feel like we're working in two silos sometimes, and I feel Community Cares can help bridge the gap. It's a tool for us to work together. I'll give you an example. We work, building relationships is really important, and we work with some schools. We work with AT Stills, who they want their students to have the opportunity to have non-related healthcare experiences in working with our clients. And that helps. That's one way to help bridge that gap. So we really appreciate that about them. And then there's other ways to partner. We've had Hospitals come and do immunizations or health checks with our clients in our shelters, or provide educational classes.
And I think between what Elva and Karen both said, again, at the campus, when we started this conversation around getting to some data portal that we could all share and see information quicker, across 15 organizations, it means spending enough time to have the relationship, build the trust, talk about what's in it for me, meaning my organization, and finding that common ground. And again, for us, it was around the client and putting the client first, and not feeling like we have to compete over dollars, and most of us are doing fundraising all the time. And so instead of looking at it as a competition and talking about the person we're serving as the center of our universe at 12th Avenue in Madison, how do we all work together? And so, a tool like Community Cares lifts everybody up, and it makes us better for the people we're serving. So for anyone listening who doesn't know what the Human Service Campus is, I invite you to come and tour, because seeing often leads to the idea generation and, we could help you, and come do this, fill in the blank. But come and talk to us, and let's have a conversation. Let's ask each other questions to understand the difference between social work and clinical care, and how do they go together. Because if we really all believe that everyone deserves equal access to healthcare in the places they live, play, and work, then we have to work together.
I really appreciate the insight from all of you. My final ask is, what is your call to action? What are the next steps? How do we make this a larger movement to really support our community?
I would say find out more about Community Cares, or find out more about all of the amazing tools that are available to become more interconnected with community stakeholders, with the partners around us. Just become more connected in that way, and bringing technology into it is making it a lot easier to navigate this whole system.
I feel like I gave a lot of suggestions seeking support, but along that line, again, the organizations at the campus look forward to implementing and rolling out Community Cares, and finding that user group or that space where we can continue to learn from each other, share the success, understand the challenges, so that we can keep improving it.
I would say in order for Community Cares to really live up to its full promise, we need organizations to participate on the platform. And so advocate, collaborate, and help fund Community Cares. If you are participating as a user in the platform, share that you are doing that with others. Invite them to participate that can. I know we have a variety of different people in our audience, so when it's appropriate to just really network and share about the platform.
So we do have our booth out with our other vendors, so please feel free to stop by and learn more from our Community Cares team. They are wonderful humans who are just happy to help. We're really excited about this initiative. We're really excited to see where the data moves. We're excited to see that now we can jump in and look at these off-platform and target some of our outreach. We might not have enough housing resources available, so how do we then engage in the housing? How do we then tie this social determinants of health data from the assessments to the referrals to the health outcomes that we have with that data in the HIE? And so my final call to you is, we are very new in this. We want to build that data. We want to grow the Community Cares network, and the data is going to really start to speak for itself. So really excited to share what's to come and where we are today. So Emily, I do think we have time for questions, if there were any.
Quite popular. Alrighty.
So the first question is, Community Cares platform seems like a rich resource for SDOH data. We are working with Contexture to address health outcomes in other ways, and I wonder if this platform can be accessed directly by public health independently, and if yes, does it provide public health access with the SDOH assets?
So I think I can take that. So we can offer the Community Cares platform to public health, to county departments. We are working with Access. We're working through various different agencies from community-based organizations. And so we do right now have our health information exchange platform separate from our social determinants of health platform, and that's going to continue to evolve. So really tying that information in from what Lisa talked about this morning with health data utility and how all of this data starts to merge and partner together. So the short answer is yes, absolutely. And we can certainly talk more about details about how to start the process. And so feel free to come up after or stop by the booth. And again, we can start on those next steps.
Okay. It seems the community organizations are having to do data entry in two systems, and this is a barrier to their participation, but also will generate inconsistent data. What is or can be done to close this gap?
Well, for homeless providers using HMIS that are required to, we could work with our provider to potentially change the system to one that will work well with community cares, or find out how to overcome the barrier of sharing that data, or find a way to populate first in community cares and then push into HMIS. Myself, I'm talking to our IT contractor, so hopefully no one from HUD is in the room. But HMIS is about reporting to HUD. HMIS isn't a client-centric tool. So, we're having conversations about, do we create some other mechanism or way to have data entry done once, but somehow we're populating HMIS so HUD can get the reporting that they want?
And we do offer some of those EHR integrations. We have single sign-on, and again, I believe the future is that that data will be more integrated. Again, we're very early in our new rollout, and so really excited for more to come, but we certainly recognize that duplicate entry, and I've even heard triple and quadruple data entry, is definitely something we want to work to eliminate, and we continue to work on what are the next steps and where are we going from here.
So this one just got upvoted to the very, very top, so people are interested. As a person's circumstances change, their previous SDOH assessment may become outdated. What are some best practices so that agencies can stay up to date on someone's SDOH data as time goes on?
I think placing it as part of the quality metrics that you're continuously improving within your data, whether it's clients or patients, and reevaluating those screenings. So if there's a capacity to resubmit and reevaluate those screenings every 6 months, every year, as part of an intake process for, I foresee it as something in our clinic where we're already collecting yearly demographic information. So we would place it within our protocols to make sure that those screenings also would get done to readdress those. And then as well as they connect to other resources, being able to assess whether they are still continuing to access those resources would be important for their care management. So really integrating into the process of the protocols for whatever organization it is.
The other thing I could add to that is, so I can put my quality hat on. I've worked in quality improvement for 10 years, and social determinants of health has continued to show up more recently in a lot of those quality programs. So targeted investment is going to have a large social determinants of health component. We also see other programs like some of the CMS programs, a lot of the ACOs are requiring the social needs assessment. There's new HEDIS measure to report out on those social needs. And so what we would see, if I go back and think 10 years ago when we were really working on how do we get depression screening done and how do we monitor that as a quality metric, I do see that continuing to evolve and probably will evolve here in the near future to have some kind of ECQM related to social determinants of health as well. But I think with depression screening, we know we have to do that on an annual basis. And so maybe that's the minimum. I would likely say that that's going to be a kind of a continuum. And so I know one of our programs in Colorado, we are actually requiring hospitals to do it upon every single discharge for a patient. And so knowing that those circumstances change for every hospital visit.
All right, thank you all so much for joining us today. I really appreciate it.